Hello everybody, welcome to my channel. Today I'm discussing psoriasis. Psoriasis is a chronic skin disorder. The outline of my discussion is going to include majorly 6 outlines. Number 1 will be the introduction. Secondly, I'll look at the epidemiology. Thirdly, I'll discuss the cause. Fourthly, I'll look at the pathogenesis. Number 5, I will look at the types of psoriasis. And lastly, I will discuss the treatment modalities. So in the introduction, what is psoriasis? Psoriasis is a chronic or rather long-lasting inflammatory immune-mediated disorder with predominantly skin and joint manifestations. How does it appear? As you can see in this picture, the lesions are usually plaques, meaning that they are more than a centimeter in diameter. They are sharply demarcated. They are erythematous meaning red, and they are scaly. Usually the scale is silver white, and once you scrape it, you will see pinpoint bleeding, which is known as the auspice sign. The silver white scale together with the auspice sign are characteristic of psoriasis. Psoriasis can either be localized or widespread. Of recent, there is a new clinical entity known as PSEMA, which shares clinical, histological, biochemical, molecular, and therapeutic entities of both eczema and psoriasis. Epidemiology. Who gets psoriasis? Psoriasis affects 2 to 4% of males and females worldwide. Males and females are equally affected. It can start at any age including childhood. However, there are 2 major peaks of onset. The first peak is from 15 to 25 years, and the second peak ranges from 50 to 60 years. The disease is common in Caucasians, however, any race can be affected. Of note, a third of patients with psoriasis have family members with the disease. What is the natural history of psoriasis? The disease is chronic with intermittent remissions. What does this mean? This means that you have periods where the disease has flared up and periods where the disease is quiescent. We shall look at the triggers in the next slides to come. What causes psoriasis? This is our third outline of discussion. The cause of psoriasis is multifactorial. There are 2 major risk factors that interplay to cause the disease. We have number 1, the polygenic predisposition, and secondly, we have the environmental triggers. Under the genetic predisposition, we have a consistently confirmed susceptibility locus known as the SORS1. So this is the only consistently confirmed susceptibility locus in many patients. We also have the HLA06:02 gene, which was previously known as the HLA-CW6. This gene is associated with early onset psoriasis and gutted psoriasis. Second, let's look at the environmental triggers. We have physical trauma. Once you beat up your patient, this can trigger psoriasis. Together with emotional trauma, these are major triggers of psoriasis. Other triggers include infections like streptococcal throat infections, perianal abscesses, dental abscesses, and importantly, HIV. We also have endocrine factors like pregnancy and hypocalcemia as triggers of psoriasis. Medications are another trigger. Trigger drugs include systemic glucocorticoids, especially when you taper them off rapidly. These may cause either pustular psoriasis or erythrodermic psoriasis. Other drugs include antimalarials, beta-adrenergic blockers, interferon, alcohol, and lithium. Of note, alcohol and smoking worsen psoriasis. So you want to tell your patient to either quit smoking or taking alcohol in order to control the disease. Furthermore, in the genetics, we have the TRAF31P2 gene that is associated with psoriatic arthritis. Remember, we said that the disease is predominantly skin and joint. So we also have the HLA-B27 allele that is a marker for sacroiliitis-associated psoriasis. So this HLA-B27 allele is also a marker for reactive arthritis, but we also have it in psoriasis. We have the MTHF R677TT genotype, and patients with this genotype easily suffer liver toxicity once treated with methotrexate. Pathogenesis. This is our fourth outline of discussion. We have the role of T cells and dendritic cells. In other words, the adaptive and innate interactions drive the immune response to produce inflammatory cytokines that include interferon gamma, vascular endothelial growth factor, TNF-alpha, interleukin 22 and 23. Other interleukins include 12, 15, 1, 6, 8, and 20. So the overall result is a reduced cell turnover time of the epidermis. Usually the epidermis takes 28 days to mature. However, in psoriasis, you have the epidermis maturing, keratinocytes maturing over 4 to 7 days. So this easily produces the plaques that you see on the skin, because the cells are heaping one over another in a very short period of time. So fifthly, we shall discuss the types of psoriasis. There are many types of psoriasis. However, I will discuss some, beginning with the most common, which is chronic plaque psoriasis. So the plaques are usually more than 3 centimeters in diameter. They are sharply demarcated annular erythematous plaques with a silver-white scale, as I mentioned earlier. This is a patient with skin of color, so you will not easily discern the erythema. You will just see silver-white scale over purplish lesions or grayish lesions. So here I have a patient with chronic plaque psoriasis, but of note, there is a small ring that is surrounding the plaques. This is known as the Voronov's ring, and this points clinically to psoriasis. Other sites affected by chronic plaque psoriasis include the scalp. As you can see, this lady has plaques on the scalp with the silver-white scale and with underlying erythema. Other sites affected by chronic plaque psoriasis include the genitals. So this patient has genital plaques of psoriasis. We also have palmoplantar psoriasis, where you have thickening and hardening of the palms and soles of the feet, as you see in these pictures on the right. Secondly, we shall discuss guttate psoriasis. Usually the lesions are much smaller than in chronic plaque psoriasis. They are more of papules than plaques. Guttate means raindrops. As you can see here, these look like raindrops on this patient. So this type of psoriasis occurs in children and adolescents. Usually these children and adolescents have preceding upper respiratory tract infections. And when you do their bloods, more than 50% of the patients have positive ASOT, anti-DNase B, and streptozyme titers. Thirdly is the erythrodermic psoriasis, where the skin is red all over, affecting more than 90% of the body surface area with overlying scale. So erythrodermic psoriasis can be either acute or chronic. It is associated with systemic illnesses, for example, temperature dysregulation, electrolyte imbalance, high output cardiac failure, and hypoproteinemia, because the patient is shedding a lot of protein in the scale. Fourthly, we shall look at the pustular psoriasis. Usually the patient is ill with fever and leukocytosis. As you can see over here, there is underlying erythema, redness, and pustulation. The skin is usually tender. This type of psoriasis is associated with withdrawal of corticosteroids and endocrine disorders like hypocalcemia and pregnancy. It is also associated with infections and topical irritants. Pustular psoriasis can be complicated by bacterial superinfection, sepsis, and dehydration. We also have pustular psoriasis only affecting the palms and the soles. In this patient, the pustular psoriasis is affecting the palms, where you can see the pustules overlying erythema. And this can easily be mistaken for bacterial infection or impetigo. Fifthly, we shall discuss the flexural or inverse psoriasis. This means that it affects mainly the body folds like below the breasts or between the gluteus, or rather intergluteal fold. And these are well demarcated erythematous plaques with minimal scale. These lesions are usually triggered by dermatophyte, candida, and bacterial infections. Dermatophyte is a type of fungus, and candida is a fungus as well. Number 6, we shall discuss nail psoriasis. Patients usually present with nail pitting, and this can affect all the 20 nails. We can also see this patient has onycholysis. Onycholysis meaning that the nail plate is being lifted off the nail bed. So usually patients with nail psoriasis have other skin lesions that may point to psoriasis. However, nail psoriasis can be the only manifestation of the disease in a patient. Once you do the fungal scrapings for culture and microscopy, usually these are negative for fungus. So lastly, we shall discuss the mucous membrane psoriasis. Psoriasis can affect the oral mucous membranes. So as you can see in this patient, the tongue is affected and it can look like a geographical tongue. A geographical tongue is a normal variant of a tongue. So this patient has psoriasis affecting the hard palate. And over to the right, we have ocular psoriasis, whereby the patient has reddening of the conjunctiva. So our last outline of discussion is the treatment modalities. Firstly, you have to grade your patient. Does this patient have mild, moderate, or severe disease? Usually mild disease is less than 10% of the body surface area affected, and moderate disease is anywhere between 10 to 30% of the body surface area affected. So severe disease is more than 30% of the body surface area affected. I know there are other scoring methods like the PASI score, but body surface area is easy to use. So in the mild and moderate psoriasis, we can use topicals and phototherapy. Topicals means that you're going to apply the treatment on the skin. So under the topicals, we have emollients, Coulter preparations, dithranol, salicylic acid, vitamin D analogs like calcipotriol, and this can be applied for like 2 months. Vitamin D analogs can be combined with topical steroids and applied twice daily for 2 months. We also have calcineurin inhibitors like tacrolimus and pimecrolimus. Phototherapy is another treatment modality. We have narrowband UVB, broadband UVB, photochemotherapy, whereby a patient can be given either topical treatment or a systemic treatment combined with phototherapy. Phototherapy can also be targeted. So in developing countries, some of these advanced treatments may not be easily available. So sometimes we combine topicals and natural sunlight, whereby the patient applies a tar preparation and goes out to the sunshine for about 30 minutes. So systemics is for severe psoriasis, more than 30% of the body surface area affected. So commonly we have methotrexate. It is a cheap drug and many patients can afford it. Other drugs include azathioprine, mycophenolate, cyclosporin A, voclosporin, pimeclorimas, retinoids like acitretin and hydroxyurea. So methotrexate is usually cheap and is preferred by many patients because it's affordable. However, you must monitor the liver function, the CBC, at least every 3 months. So lastly, under the systemics, we have the biologics, and biologics are for conventional treatment resistant psoriasis, meaning that if your patient is not responding to the treatments I mentioned earlier, then they can be offered a biologic. These are targeted therapies. For example, anti-TNF alpha, as we saw earlier, it is one of the cytokines that is produced. So some of the drugs target these cytokines. For example, anti-TNF alphas like infliximab, adalimumab, and etanercept. We also have interleukin 12/23 antagonists like ustekinumab. We also have interleukin 7 antagonists like secukinumab. So these are much more expensive treatments, so you must counsel the patient about the cost. However, they work very well. Generally, we avoid systemic steroids in the treatment of psoriasis. As we saw, once you start tapering them, patient can get either pustular psoriasis or erythrodermic psoriasis. Thank you for listening. Please subscribe to my channel. I'll see you in my next video. Bye.